Hi guys, welcome back. We'll be talking about disease of the anterior pituitary, where we'll start by discussing about acromegaly. But before I do that, I would just like to inform you that the diseases of the posterior pituitary topic has been covered in the kidney section. So if you would be searching for diabetes insipidus and SIADH, you would not find it in the endocrine component. You'll find it in kidney section, where I've described it in combination with Liddle syndrome, Gitelman, then diabetes insipidus and SIADH. Now, for acromegaly, before I describe the clinical manifestations, I would just like to say that to WWE wrestlers, as kids, at least we tend to watch this fake wrestling, WWE. So, Kali, the great from India, and then Andre the Giant. If you just Google in word the Andre the Giant, or regarding Kali's case, both were identified were having a pituitary adenoma, and the excess of growth hormone primarily occurs after puberty. This is in contrast with gigantism, where the pituitary adenoma will be developing before puberty and there would be a tremendous increase in the height of an individual. But in acromegaly, it's mainly a acral enlargement that is predominant. So let's just summarize the important causes of development of acromegaly. The first and the foremost would be that you are aware from physiology that somatotrophs are one of the most predominant cells in the anterior pituitary, and the patient could be having is a presentation of a somatotroph adenoma, which will explain the excess production of growth hormone. However, in some cases, there is a possibility that this gentleman who comes to you or a lady who comes to you might be having a tumor which would be originating from this particular cell that is called as mammosomatotroph. Now, when I write this word mammosomatotroph, immediately that comes to your mind would be that there would be excess production of prolactin also simultaneously. So yes, guys, in a mixed mammosomatotroph adenoma, what happens is that usually the clinical features of acromegaly are initially masked by the clinical features of excess of prolactin, because the clinical features of prolactin excess are very, I would say, that would bring a male patient immediately running to you, because this man would be having is development of galactorrhea. And apart from this, because prolactin inhibits the release of LH and FSH, so the impact would be felt with respect to hypogonadism as well. So what I'm trying to tell you is that if it's a mixed mammosomatotroph adenoma, then hyper, both hormones are increased, that's okay, but hyperprolactinemia symptoms, especially in a male patient with galactorrhea, would be like very, very, at that they would make the patient seek your medical advice much more faster as compared to features of acromegaly, which will take some time to develop. Then there could be excess of GHRH, that is growth hormone releasing hormone, and GHRH would be coming from the hypothalamus. So he could give you, or one of the options in the MCQ could be that of a hypothalamic hamartoma. Though in the exam, he can not only ask you regarding not only a hypothalamic source, but he might even try to talk about an extra pituitary, extra hypothalamic source of GHRH. I repeat once again, hamartoma or a choriostoma. These are two tumors from the hypothalamus that would be causing is excess of GHRH, and this would explain that if GHRH is more, then GH will also increase. But from the exam perspective, what I'm trying to tell you is that the examiner might try to trouble you by asking you regarding a extra pituitary growth hormone releasing hormone source. Now, this is point number 4, which is important from the exam perspective, in a sense that carcinoid tumor. Very surprising, because when we read about carcinoid tumor, everything that flashes before our eyes is excess of serotonin, excess of histamine. So there's gonna be flushing episodes, there's gonna be asthma-like episodes in a person. And here, what we are talking about in carcinoid tumor is excess of GHRH and then acromegaly-like manifestations. But because this is rare, it obviously has to be kept in mind. And similarly, he might even try to ask you regarding extra pituitary growth hormone production. Now, when I say extra pituitary growth hormone source, then there can be two possibilities, and listen to these points carefully. One could be that the person could be having is a ectopic pituitary tissue. Now, looks surprising, ectopic pituitary tissue. The pituitary per se is such an important gland, a master gland in the body, and it's present at an abnormal site. So where it can be present is nasopharynx. So if a person is having an extra pituitary source, that there could be a tumor developing in the nasopharynx or a midline tissue, and that could explain it. Or for that matter of fact, extra pituitary growth hormone space or source would be a surprising, a pancreatic tumor. I mean, traditionally, when we read about pancreatic tumors, we read about insulinoma, glucagonoma, somatostatinoma, rare ones like VIPoma. But today I'm telling you, a pancreatic tumor could be producing excessive growth hormone, and that could result in development of acromegaly in a patient, though overall the number one cause would anyway be a somatotroph adenoma. Now let's look at what are the clinical manifestations. What did Andre the Giant or what did Kali go through? So let's look at the clinical manifestations developing in these patients. The first and the foremost thing that I would like to tell you is the leading cause of mortality in these patients would be cardiovascular mortality, because you get a visceromegaly, somatomedians are in excess, so you get a cardiomegaly, and there's a limit to the size of what the heart can increase. So a lot of these patients would be having is arrhythmias, fatal arrhythmias that could result in death. I mean, Andre the Giant, he died because of cardiovascular complications. So, I mean, if he just says what's the leading cause of death in acromegaly patients, your answer would be given as CV mortality. The first and the foremost thing that I would like to draw your attention would be the name is acromegaly. So that means that there would be a acral enlargement. And when I say acral enlargement, that means that there would be increase in the size of the hands of these patients. In majority of questions, right, the first line of the MCQ, he will say this word, spade-like hands. The moment he says this, spade-like hands, spade is the instrument that is used in construction purposes to pick up that cement and concrete. So big, large hands in a person would be present. And from the clinical domain, I can say that, suppose a patient is staying in a Western country and it's very cold out there. So like in Western country, because it is very cold, people tend to put gloves. And the problem in this patient is that the size of the gloves that he's having to wear, that is increasing because the hand size is increasing. So therefore the pair of gloves needs to be replaced. Or I can say that because the finger thickness in this person will also increase. So if he's having a ring, like this guy has a wedding ring in his finger, so because of the increase in the finger thickness of these patients, that ring might actually get impacted. Similarly, even the shoes size of this person, he will have to purchase a new pair of shoes every 6 months or every year, and to a limit that the feet are so big that in a routine store, the shoes that would match up to his foot size would not be available. So acral enlargement, I think, would be very characteristic terminology to identify this. And along with this, the facial features of these patients would also be given in the question. Like, for example, you would be having is a frontal bossing present in a patient. There would be a very prominent fleshy nose. So, I mean, when I say frontal bossing and a large fleshy nose, the examiner may actually not write or may choose, instead of writing these two terms, he might just use the word coarse facies. In these patients, you will also notice that the sweat glands would be they would also become relatively bigger. So the person will have excessive sweating, that is hyperhidrosis. Even the sebaceous glands would be working, or they're relatively bigger, so they would be producing more amount of sebum, so acne component can be present. And in these patients, when it comes to the lower jaw, one you have is a mandibular growth, and the mandibular growth occurs in downward direction. If I just focus on the chin of Kali, or if you look at chin of Andre the Giant, I mean, he was called Andre the Giant primarily because of this fact that the facial features were very, I would say, very in your face. I mean, a person who's looking very bulky, a person who's having this very prominent jawline with prognathism, that would be terms that would help you in identifying acromegaly in a question from a clinical domain. And when it comes to the teeth of the patient, because the jaw is growing, the lower jaw is growing, so there would also be a gap between the teeth. So you might actually read the statement, widened space between the lower incisors. That's mainly because of the growth of the lower jaw in the person. And apart from this, I mean, though I think that these two descriptions that I've given you are more than sufficient for identifying the disease, still there would be some parameters that he would love to ask, because 1 and 2 is pretty straightforward. You see, in acromegaly, height will remain the same. Height is not going to change dramatically because the problem occurs after puberty. Now, what parameter would you be using to monitor the growth in the patient? Like if I say gigantism, we have growth charts in pediatrics. The child's growth charts would be, I mean, his growth is going to be disproportionate to all the routine charts that we have. So we can easily identify. But when it comes to acromegaly, he would like to ask you regarding this term. heel pad thickness. Heel pad thickness is the radiological parameter. I'll be telling you the cutoffs for it, or I can tell you the cutoff right now only. That would be more than 25 millimeter. Though, I mean, heel pad thickness can be increased even in people having barefoot walking, because of the callus formation in the foot. But then I can say heel pad thickness is a good parameter or a good monitor, a good way to monitor the growth of this particular patient. Then as the body weight will increase, the joints will be affected. A lot of these patients might be having an abnormal gait. If you see Khali walking, you will notice a peculiar gait that he has. That's mainly because of the premature osteoarthritis of the knees that would be developing in these patients. So arthropathy and kyphosis would be noticed in these patients along with carpal tunnel syndrome. Traditionally, in endocrinology, every time you read about carpal tunnel syndrome, two things that should always come to your mind is hypothyroidism, and second would be acromegaly, the current topic. Then if I go towards the important vital organs in the body, I already said that there would be visceromegaly, there would be increase in the size of the heart of these patients, so cardiomyopathies. And once you get a cardiomyopathy, a dilated one, then subsequently the risk of arrhythmias would increase in these patients. And in fact, the usual cause of death in these patients would be an increased cardiovascular mortality. The survival of these patients is reduced. I'll write that once again. The leading cause of death in these patients would be a cardiovascular mortality. If cardiovascular mortality is not given, then it could be stroke also. That's again because a lot of these patients would be having hypertension, because you see, if the body mass is increased, if the overall body mass is increased in these patients, then peripheral resistance will also increase, and that will explain the hypertension in these patients. So cerebrovascular complications can occur. And apart from this, even these patients might be having respiratory issues, because the tongue size will also be relatively bigger, and they could be having is a OSA, that is obstructive sleep apnea. Obstructive sleep apnea worsens hypertension. You can listen to obstructive sleep apnea in the respiratory section, that where I've discussed it, and that tends to worsen systemic hypertension in a patient. And overall, I can say, because of a combination of cardiovascular problems and CNS issues due to hypertension and obstructive sleep apnea putting strain on the heart, the survival of these patients will be reduced by approximately 10 years. Like suppose a person was suppose the lifespan in America, I'm just saying randomly, suppose lifespan in America is 75 years. So acromegaly patient would be living about 10 years, relatively lesser. That is, the person would die by 65 years of age. So life expectancy is shortened. They have done this and calculated this in clinical studies, that life expectation in an acromegaly patient would be reduced by approximately 10 years. And another problem that could be occurring is from the GI perspective, that they could be having is colonic polyps. Now, every time you have polyps in the colon, surface area is more, and every time surface area is more, things can go wrong, because cells could be having is a atypia, and subsequently even a risk of colonic malignancy or colonic adenocarcinoma can be developing in these patients as well. But if they give you all of these and they ask you to select one, then I've already told you that the primary answer of yours would be a cardiovascular mortality. Then over and above this, you will also notice that these patients would be having is a impaired glucose tolerance. Why that happens is because growth hormone per se, apart from hypertension issues, I want to tell you that even diabetes mellitus might be occurring in these patients, or if not diabetes mellitus, they might be in the pre-diabetic range. Growth hormone tends to increase the blood sugar values. Therefore, if you want to check out the fasting blood sugar values of these patients, or if you're going to check out the 2-hour value in this patient after a glucose tolerance test, you will notice the values would be elevated. In some of these patients, you could be having impaired fasting glucose. Impaired fasting glucose, as I've told you, is 100 to 125 milligram, whereas 2-hour value between 140 to 199 is called as impaired glucose tolerance. I said two statements. One I said was impaired fasting glucose, that is 100 to 125. Then could be impaired glucose tolerance, that would be 140 to 199. However, in some patients, there is a possibility that the fasting blood sugar might even go in the diabetic range, that is going to be 126, and 2-hour value of more than 200. So, I mean, depends. Early presentation, you would have impaired fasting glucose, impaired glucose tolerance, and a later presentation, diabetes mellitus as a manifestation could be occurring in these patients. For point number 9, this is relatively less commonly seen, but from the exam perspective must be known to you that galactorrhea can also be a presentation, because sometimes you could be having is a mixed mammotroph somatotroph adenoma. Now, once you read about galactorrhea, I also want you to remember about other important causes of galactorrhea which have been asked in the exam in the previous years. I mean, the first thing that comes to your mind every time you read about galactorrhea is prolactinoma, but you need to remember things beyond this. Apart from prolactinoma, remember drugs can be causing galactorrhea. That would be antipsychotic drugs. Though there are multiple side effects of antipsychotic drugs ranging from akathisia to tardive dyskinesia, but yeah, galactorrhea is also to be remembered. Then is chronic kidney disease. The logic behind that would be that prolactin is excreted via the kidney, and if the kidney will malfunction, prolactin will not be excreted, so the levels would be relatively higher, and therefore CKD patients can have is a galactorrhea. The next point that I'm saying would be the most important point from galactorrhea perspective or exam perspective is that patients were having primary hypothyroidism. Now, why primary hypothyroidism has galactorrhea is discussed in the thyroid topic per se, but I want you to remember at this moment, primary hypothyroidism is an important MCQ cause for development of galactorrhea. So, two important endocrine causes that you have been taught today for galactorrhea is the current topic of interest, acromegaly and primary hypothyroidism, and you do not get this with secondary hypothyroidism. I mean, another question was, where would you not be having a galactorrhea? In secondary hypothyroidism, there would be damage to the pituitary. If pituitary will become less in the patient, then prolactin values would be lesser. Repeat again, if a person is having secondary hypothyroidism, it means pituitary is involved. If pituitary is involved in a patient, then the prolactin values would be lesser. Rather, you would be having is a failure of lactation in a patient. So do remember these are two important endocrine causes for galactorrhea. And coming back to the topic, because the person is having a pituitary adenoma, this pituitary adenoma can cause visual field defects also, which would be in the form of a bitemporal hemianopia. Though when it comes to point number 9 and 10, they are relatively rare findings, but yes, that visual deficit of bitemporal hemianopia should be kept in mind every time you read about a pituitary adenoma. Though visual deficit is relatively more common with prolactinomas. A lot of these are macroadenomas. So, I mean, you need a size of pituitary more than 10 millimeter. To cause a development of a visual deficit, and most patients would come to medical attention earlier than that. And I can say from the exam perspective that every time you read about spade-like hands, you read about coarse facies in an individual, increased heel pad thickness more than 25 millimeter, which is used for monitoring growth of these patients, then the clinical information would be too characteristic to miss in an exam. And let's now focus on the workup of these patients. Now, coming to the workup, the first investigation, that would be a screening test that would be done for identification of acromegaly in a suspected case, would be to check out the values of IGF-1. That would be insulin-like growth factor 1 levels. At this onset, I would like you to remember that insulin-like growth factor 2 levels help in prenatal growth, and insulin-like growth factor 1 helps in postnatal growth. So screening test would be IGF-1 levels. The major interest of the examiner would be in this topic to ask you regarding the investigation of choice, which would be answered by you as a oral glucose tolerance test. Looks surprising when you tend to read this information for the first time, but is definitely true that growth hormone and sugar, I would like to put it like this, growth hormone tends to increase the value of sugar, but if you administer 75 grams of glucose to somebody, I'm talking about a normal individual at the moment, if you administer 75 grams of glucose to a normal individual, then glucose in a normal individual should suppress the production of growth hormone. This is for normal people, but a pituitary tumor is not going to respect physiology. I mean, if you give 75 gram glucose, it is supposed to cause suppression of the growth hormone, but a tumor will not respect physiology. Rather, the tumor will say that I'm going to do or I'm going to go my way. So as a result of it, the interpretation that could be given in the question will say failure to suppress. That's the important statement from the exam perspective. He will say failure to suppress growth hormone production. And he might even give you some values also, though values are not important, but I'll just say them for the sake of completion. Failure to suppress growth hormone levels to less than 0.4. And I mean, those values are just for the sake of discussion here. They might be described in nanogram per ml or in micrograms. I think that would be easier to remember if I say it in micrograms per liter. The point is, though we have ultra sensitive assays available, which can check out growth hormone values even lesser than this. See, growth hormone in our body is not produced in a continuous fashion. It is produced in a pulsatile fashion. So the query of some people is, sir, why don't you just check out the growth hormone value? Because growth hormone is having a pulsatile release. So I cannot regulate, I cannot point out whether I've taken the sample at the nadir or at the peak per se. day. And more importantly, sugar consumption by any individual, like if you take a sample after meal, will be different from when you take a sample before the meal. So what we do in our patient is give glucose, and we try to suppress growth hormone, and anyway the tumor is not gonna respond to this. And in these patients, another finding that might be seen is that when you give oral glucose tolerance, when you do this test, even prolactin levels in these patients might be increased. Because I told you already that these patients are having, some of these patients could be having is a mammosomatotroph adenoma. So prolactin values would be increased. And other hormones, like, the query a lot of people is what happens to TSH in these patients or ACTH. The values can be normal or they can be suppressed. The reason for that is that there is a tumor in the pituitary. So the mass effect of the tumor can impact other cells also. I mean, one cell is having uncontrolled reproduction or mitosis, so the other cell's function can be hampered also. So other hormone values can either be normal or lesser. That's mainly because of the mass effects. And to identify that why is there a failure to suppress growth hormone, why there's a hyperprolactinoma, ultimately we will be doing a MRI head to locate this tumor. And majority of cases the tumor will be located here only, but I told you could be having is a ectopic growth hormone also that could be coming up from a tumor in the midline. I mean, the pituitary tissue could be present in the nasopharynx of the patient, which is a little peculiar, but yes, should be remembered. Then we could be doing an X-ray of the foot of a patient, lateral view. And on the X-ray of the foot in a lateral view, what we try to check out is, and I've sensitized you to this, is heel pad thickness. Heel pad thickness, it can be increased even in patients who are having callus formation in the foot, even hypothyroidism, even peripheral edema. So I'm not saying that this is a very accurate way for identification, but yes, the higher is the heel pad thickness in acromegaly, it means that person, because lots of time you might be managing patients medically. Ideal treatment for these patients is go ahead with transfemoral surgery, but a lot of time patients might be frail or a person might refuse surgery. So you are going ahead with medical treatment. And if you want to check whether your medical treatment is working or not, then you need to monitor heel pad thickness, because this heel pad thickness at least should not increase. If your drugs are working, if you want to shrink the pituitary tumor, then heel pad thickness should not increase, because if it's showing an increase, that means you need to maybe give additional drugs to the patient, or maybe the dosage is not right, or the patient is not compliant per se. Heel pad thickness values are given different in different books. I can say size of foot, heel pad will vary according to race. In some books, it's more than 21, sometimes 23. I've given the upper limit here. Values more than 25 millimeter would mean that yes, there is a problem. When I say problem, it could be simple one, callus, it could be peripheral edema. We need to rule that out. But in acromegaly, heel pad thickness is used to monitor progression of the disease, and even clinically, we would like to see that at least it should not worsen. I'm not saying it will regress, but I'm saying if it's increasing, it means that either the patient is not compliant with the drugs per se. And if he says, how would you manage this case? Then the first answer of yours is surgery. Now you very well know, whenever you tell an Indian patient, sir, surgery kara lo, he will say, sir, don't you have another option? So we are going to talk about what drugs can be used in these patients. But in the exam, suppose he gives drugs also and he says surgery also, then your first answer would be given as transfemoral surgery is the treatment of choice for this patient. Now, pre-operatively to shrink the tumor, and I can say patients who refuse surgery, why am I using drugs? One is refusal of surgery. Another possibility is patient is very frail. He is already having a cardiomyopathy, and the anesthesiologist is saying that giving anesthesia to this patient would be a little risky. So frail patient, refusal of surgery or pre-operatively to shrink the tumor. I can be using a couple of drugs, and here your knowledge of pharmacology would come in. The drugs that you'll be using here would be somatostatin receptor ligands. One of the drugs, important one to be remembered, is octreotide. We have as a long-acting formulation available for it. Or we can be using other drugs also like lanreotide or pasireotide. Now, once you get the names right, then the next thing that they can ask you with respect to these drugs would be that, why are you after all using these drugs? So a pituitary adenoma expresses some receptors. The name of these receptors would be SST2 and SST5. And these receptors which are expressed by this adenoma, they are responsible for this excess production of growth hormone. So once you affect these receptors, then the production of growth hormone tends to become reduced, or I can just say somatostatin, is an inhibitory hormone per se. I mean, somatostatin, even in the GI tract, we have studied it as an inhibitory hormone. So we are using that inhibitory effect here as well. So from the exam perspective, if he says what drugs would be used, the broad category that you will answer will be SRL. When I say SRL, I mean somatostatin receptor ligands. What these SRLs will do is that they are gonna reduce the production of the growth hormone from the adenoma per se, which expresses these receptors by blocking them and causing a significant improvement in the general condition of the patient. In fact, if he says, what is the first thing that you notice in a person once the surgery has been done, then obviously all the growth hormone levels will begin to fall, IGF-1 levels will begin to fall, but soft tissue swelling, which occurs in these patients, would be improving immediately. I repeat that. Post-operatively in a patient of acromegaly, what finding can be seen in the recovery period itself is a reduction in the soft tissue swelling in the patients. Though if a patient refuses surgery, then the following drugs that I've explained to you can be used: octreotide, lanreotide, or pasireotide, which could be in the form of monthly injections that would be administered to the patient. However, whenever a surgeon is operating on these patients, there is a possibility that if he operates very aggressively, aggressive surgery in this case can result in persons developing then hypopituitarism. And if he is, I would say, not very aggressive, then there can be a recurrence of the tumor as well. I said two things, and that the figures given for that are 10% and 15% in Harrison. He says that if you do aggressive surgery, you have a problem. Problem is hypopituitarism. You do less aggressive surgery, there can be a recurrence of a tumor as well, or there might be a poor response to the initial drugs. So if you're having poor response to SRLs that I just explained to you, or there is a recurrence of a tumor, then you could be using another drug, which is pegvisomant. The mechanism of action of pegvisomant, from pharmacology, would be that it will block growth hormone receptors per se. And the moment you block these growth hormone receptors, then the advantage would be that the blockage of these growth hormone receptors would mean that even if the tumor is producing excess of growth hormone, the excess growth hormone will not be able to produce its effects per se. Next up, we're going to talk about Sheehan syndrome, which would be a post-obstetric event. A patient has suffered from postpartum hemorrhage. There would be hypovolemia, and then subsequently the hormones which are produced from the anterior pituitary, 6 of them which are listed here, would be compromised. The question in the exam said, which is the first one to be affected? Now, the logic to be used by you is that somatotropes per se would be occupying maximum space in the pituitary. They're the most abundant cell in the pituitary. And once the blood supply of the pituitary is hampered, then somatotropes would be affected and the growth hormone levels will begin to fall. The question said, what is first to fall in patients of Sheehan syndrome? Answer is growth hormone levels. And what would this cause clinically? Then this would cause hypoglycemia. And because of this, the person would be having his mood swings or emotional lability. And most of the time, this would not be identified, because if a lady is having tearfulness or she's having mood swings or emotional lability after delivery, we might be thinking that she's suffering from postpartum blues. So most of the time, the growth hormone deficiency is not identified initially. Then subsequently, the values of ACTH will begin to fall, and ACTH plays a direct role in release of cortisol. And you can therefore see that once cortisol will begin to fall, then again, this is going to worsen the pre-existing hypoglycemia component in the patient. But both of these are difficult to identify initially. In fact, if he says acute presentation of Sheehan syndrome, then acute presentation of Sheehan syndrome would be that of prolactin levels reducing, and therefore this lady after delivery would be having is a failure of lactation. I repeat once again, first and foremost, you need to understand that the chronic presentation in Sheehan syndrome is more common as compared to the acute presentation per se. And in chronic presentation, I mean that the symptoms of hypothyroidism in a patient, or I would say amenorrhea in a patient, they would tend to develop relatively late or gradually. So diagnosis is usually made late. In acute presentation, the manifestations would usually be in the form of failure of lactation. The first two, I mean, I agree, growth hormone is the first one to fall, but the symptoms of hypoglycemia may not be identified or might be misdiagnosed as that of postpartum blues, which is why if he specifically says in the exam, acute presentation of Sheehan syndrome, then okay, your answer is failure of lactation. But if he says what is the first one to fall, then the answer is growth hormone deficiency, and overall chronic presentation is more common as compared to the acute one. Most cases will come to attention when this lady will be having problems with conceiving once again. Either the question will use the word secondary amenorrhea because LH and FSH values will fall, or you might just say secondary infertility. Other features that would be seen in these patients would be because of secondary hypothyroidism. Because once TSH is lesser, there would also be a decreased values of T3 and T4, and due to this secondary hypothyroidism in the patient, when you do a thyroid function test, you will notice that T3, T4, TSH all will be reduced. The symptoms would be in the form of constipation. I mean, obviously the traditional things I'm not writing here like cold intolerance because they're very in your face kind of a symptom. So most patients when they come, they would be having is a weight gain along with this constipation and then alopecia. And subsequently, I mean, the myxedema component can develop in these patients as well. So how would you identify Sheehan syndrome in a patient? You need to do imaging and you will be checking out prolactin levels as well. When you do imaging in these patients, MRI head will be showing is a anterior pituitary destruction. And along with this, if it was acute presentation, I was having failure of lactation, prolactin levels would help me in confirming the diagnosis as well. Now, what would you do for management of these patients? Then our primary objective would be hormone replacement. And here the question will say, which is the first replacement that would be done in the patient? Then your answer would be dexamethasone because I want to neutralize cortisol deficiency, which is causing hypoglycemia. Though hypoglycemia is occurring both because of growth hormone deficiency as well as hypocortisolism, but then cortisol is the stress hormone in the body. So if he says what is first to be replaced, I would like to replace cortisol deficiency. Along with this, because these patients would be having decreased values of estrogen in their body thanks to the low values of FSH, so we need to give estrogen, but giving estrogen alone is again risky because it increases risk of breast cancer, etc. So therefore, we would be using OCP / combined oral contraceptive pills for these patients, which would be having is estrogen as well as progesterone. One advantage of giving both estrogen and progesterone would be that progesterone would progesterone causes withdrawal bleeding, so I mean she would be having is regularization of her periods as well, and apart from this the harmful effects of estrogen alone can be neutralized. Because these patients would be having hypothyroidism, so levothyroxine manifestation or levothyroxine supplementation would be recommended in these patients. And at this juncture I would just like to say that in sometimes in the exam he may deliberately ask you regarding a non-obstetric cause of damage to the pituitary. If you have an obstetric cause of damage to the pituitary, we all know we are going to call it Sheehan syndrome. But then you should also be familiar with this terminology that I'm writing right now, that is Simmert's disease. This would be like suppose a person is having hypertension and hypertensive crisis has compromised the blood supply of the pituitary, or this is an Afro-American child who's suffering from sickle cell anemia. There's a sickling crisis. So the message is every time you have is a non-obstetric damage that is occurring to the pituitary, then you will say this would be Simmert's disease. The manifestations, however, will occur in a similar fashion. Somatotrophs would be the initial ones to be affected. And, for the exam perspective, I can say, suppose I'm describing a male patient. So even if I say male patient, everything would be same. Dexona would be same. Levothyroxine would be same. But obviously to a male patient, I'm not going to give estrogen and progesterone. I will be giving testosterone to the patient. So the only additional point which I would like to say from the treatment domain is that point number 2 of treatment would be gender specific and depending on male or female patient who's affected. Like in Simmert's disease, hypertensive male patient suffered from damage to the anterior pituitary. So I'm going to give Dexona, I'm going to give levothyroxine and testosterone to the patient. In one of the previous year MCQs, he said, I think it was FMG exam, and the question said, which of the following would not be recommended for management of these patients? Then it is fludrocortisone, because fludrocortisone has a predominantly mineralocorticoid activity, and in these patients the deficiency is not of mineralocorticoids. The deficiency in these patients is primarily that of glucocorticoids. So I would like to replace glucocorticoids by giving Dexona to the patient. At this junction, I would also like to make it clear that if all the 6 hormone production becomes lesser from the anterior pituitary, then the term that we use to describe that would be called as panhypopituitarism. And the question then arises, then what would hypopituitarism mean? So if you encounter the term plain hypopituitarism written, it means that only growth hormone deficiency is present in a patient. Growth hormone deficiency, if it is present since birth, that is in case of a child, then the height of the child will not increase. You are aware, length of an Indian child at birth would be 50 centimeter, becomes 75 centimeter at 1 year, and 100 centimeter by 4.5 years of age. So this child is not going to grow like a normal child, and you would be having is just short stature. The technical definition of short stature would be that the height of the child, I mean, this is going to be the shortest of the shortest children as far as the growth charts is concerned, height less than the third centile. Other features that you'll notice in this child would be a shrill voice and doll-like faces. So though you read about doll-like faces even with respect to von Guericke syndrome, which is a glycogen storage disorder, but why am I discussing this topic is not that I want to teach you this pediatric domain. I am discussing this because I want to talk about a test that is useful for diagnosis of hypopituitarism, which is in striking contrast to the test that I mentioned for acromegaly. While I was teaching you acromegaly a couple of minutes ago, if you're listening to me carefully, I talked about oral glucose tolerance test. Now I am sensitizing you to this term, insulin tolerance test. So just get this reflex going. Just like you are comfortable now with oral glucose tolerance test being used for diagnosis in acromegaly, I want you to remember insulin tolerance test is useful for, just invert the words, instead of glucose, insulin tolerance test for hypopituitarism. Now, insulin tolerance would obviously be a slightly risky procedure because it can trigger hypoglycemia. So instead of doing our insulin tolerance, we might even be doing is the insulin challenge test. My objective was mainly to sensitize you to the investigation. I mean, because growth hormone levels can fluctuate and would not be produced in a linear fashion. So these provocative tests are the one which are recommended for diagnosis of these patients. And once we've done, I mean, we need to give growth hormones in injectable format. Earlier, growth hormone was made from cadaveric pituitary, but then that used to cause prion disease. So now we do not have prion disease, primarily because growth hormone that we are giving to the patient would be manufactured by DNA recombinant technology. And obviously we need an endocrinologist who would be doing a great job at giving these injections at regular basis to ensure a normal growth in the child. I would like you to read about hypopituitarism from pediatrics domain as well. But the test that I mentioned is the main reason why I would like you to remember it. And at this juncture, I can say that in the topic of endocrinology, the entire game is all about, I mean, he will waste your time in 2 or 3 lines describing the clinical profile of the patient, which will be in your face. Like you read about spade-like hands and increased finger thickness, increased shoe size, you know it's acromegaly. And he will then ask you what test is used for diagnosis. I'll just mention some random names in endocrinology, which I've already discussed in the earlier section of the app. But this is just to develop a reflex in your mind with respect to what is the best test to confirm the diagnosis of these endocrinological disorders. Diabetes insipidus and SIADH have been discussed in the kidney section, disease of the posterior pituitary, as I told you right in the beginning. But then let's just jot down a couple of more names here, and then we'll compile a list of the important confirmatory test to be done in these patients. Like the topic that I've jotted down at the moment and was taught, just a few minutes back, was hypopituitarism. Then would be a patient who's having Cushing syndrome. Though one of the causes of Cushing syndrome can be Cushing disease, where there's a pituitary adenoma present. And not to forget, hot favorite of our examiners, pheochromocytoma. So once I've jotted down the names here, let's have a quick recap with respect to the test that you'd be doing. For acromegaly, it is oral glucose tolerance test. For cons, the test to be done is a saline infusion test. And though in the routine video, I've also talked about salt loading test, but then it's a little riskier one. It can cause BP to spike. So saline infusion test would be relatively safer as compared to, I can say, salt loading test. For Addison, we'll be giving ACTH stimulation, and because Addison begins with the A and ACTH stimulation again begins with the A, lot of people are able to figure this out, and therefore the examiner will use the term co-centropin test for Addison disease. For diabetes insipidus, the test that would be done would be water deprivation test. And when it comes to SIADH, the test that would be done would be called as water loading test. It would look very simple to you at this juncture, yes, but I've seen people, messing up in the data, and they tend to invert this data of deprivation versus loading. So just be sensitized to that. For hypopituitarism, I've already told you today, insulin tolerance test, that's a repetition and I think will become a long-term memory. For Cushing syndrome, we need to do a dexamethasone suppression test. If he says high dose versus low dose, then we initially perform is a low dose dexamethasone suppression test. I mean, high dose dexamethasone suppression test is for etiological diagnosis. It lets you know what is the cause, ACTH dependent or an independent cause per se. But low dose dexamethasone suppression should be the primary answer for Cushing syndrome. Along with this, urinary cortisol values would obviously help you. And then for pheochromocytoma, yes, we can do urinary catecholamines, we can do plasma catecholamines. But in the blood, even if plasma catecholamine is given, then your first answer should be with respect to metanephrine, that is plasma free metanephrine values or levels will be useful for diagnosis of pheochromocytoma. So I would say that this was more of a miscellaneous slide where I made you practice important investigations which are to be done in other endocrine disorders. And to finish this topic, I lastly mentioned regarding pituitary tumor, that is prolactinoma. In fact, if he says a functioning tumor, only then the answer would be given as prolactinoma. If you just get a general question, if he just says this statement, what is overall the most common pituitary tumor? Mark my words there. I said functioning, then the answer is going to be answered as prolactinoma. If he just says most common pituitary tumor, then the first answer of yours would be that a non-functioning adenoma. By non-functioning adenoma, I mean this tumor will definitely produce a mass effect, but it will not produce any hormones per se. And just for the sake of completion, though I have already said that verbally, if he says this word, most common functioning pituitary tumor, that is when your answer would be given as the topic of interest, that is prolactinoma. And the next one line that I'll write before you will help you understand both the clinical features and the treatment of this condition. The single line I want you to remember is that dopamine in the brain is having an inhibitory control over release of prolactin. And prolactin in turn would be having an inhibitory effect with respect to LH and FSH. And now I'm describing a 30-year-old lady who, unknown to her, though she's having occasional headaches, she might be thinking she's having migraine. Her physician is also treating her for migraine. And this lady, unknown to her, is harboring a pituitary adenoma, which is causing excess of prolactin. Because of excess of prolactin, the values of LH and FSH will begin to fall. So because LH will begin to fall, so therefore ovulation will be hampered. So she will be having anovulatory cycles and will be not able to conceive. And because of the FSH values also downgrading, she will be having is a development of amenorrhea. So most MCQs that are going to be asked to you for the prolactinoma topic will begin by describing infertility. It could be primary or secondary depending on whether the patient is married or not. But let's say 30-year-old lady, she's already having one kid, she's trying for the second one, and now she's developed is a secondary infertility. In these patients, if it becomes a macroadenoma, if the size of the tumor is more than 10 millimeter, then even visual deficits will occur in these patients. That is going to be a bitemporal hemianopia. I mean, every time you have is a pituitary tumor pressing on the optic chiasma. Bitemporal hemianopia or visual deficits could be mentioned in a question, but this would be a relatively late presentation in the disease. So for diagnosis purposes, we are going to do a serum prolactin, which will be shooting through the roof. We are going to do a MRI head, which will help us identify whether currently the patient is having a micro or a macroadenoma. And then we need to go ahead with treatment. Now for treatment, there are two drugs which are available. One we can use is cabergoline, or the second one that we can use is bromocriptine. And though we have talked about bromocriptine even in Parkinsonism, but just once again, bromocriptine, what it's going to do is that it's going to affect the levels of dopamine. It's going to cause an increase in the level of dopamine. You can very well understand that if prolactin is more, if I want to counterbalance, The words are, if I want to counterbalance the effects of prolactin, I can increase dopamine because dopamine has a inhibitory effect on the release of prolactin. So I'm going to prevent this excessive release of prolactin from this tumor by using cabergoline slash bromocriptine for the patient. So drug support is anyway important. If it's a macroadenoma, which would be relatively less common, then surgery would be required for these patients, though medical treatment is the best way for management of majority of patients of prolactinoma. And from the exam perspective, I can say that this topic is relatively a simpler one. The clinical domains are simpler. It is just that couple of investigations that I mentioned, like I mentioned screening test of IGF-1 for acromegaly versus investigation choice of oral glucose tolerance test are the points which are to be remembered. And you are going to do great in your career. I mean, I've just a few words of motivation here, that you guys are like, there's a lot of negativity in social media with respect to doctors per se and our field per se, that our colleagues will also say and seniors will also say that, the career does not progress. But that's not really exactly true, because once you go through a certain, grind, I will say, then things become relatively easier. So I'm not saying it's the easy field, but yep, it's not as difficult as it is made out to be. And I'm very sure that you guys are gonna go through this grind and come out with flying colors. Keep hammering.